My deal today is talking about transposition and aspect of supraventricular tachycardia. And as an electrocardiologist or ablationist, the heart is a little bit beating faster coming to this topic. And as everybody is expecting me showing an EKG at the beginning, I do so. This is a grown-up patient showing a typical mixture of brady and tachycardia. This example here, he had more than 160 kilogram of body weight, which did not make the procedure, the ablation procedure, more easy to be done. And at the initiation of the sedation by the anesthesiologist in our electrophysiological lab, for this patient, we had an anesthesiologist, we all got frightened because of the bradycardia that was induced next to the tachycardia he could show. And this is not only in the electrophysiologic setting what we see, this is even in the clinical world. When we look to these patients, this is just an excerpt from the Holter monitoring of a 44-year-old patient with a master procedure, classical transposition of the great arteries. And don't try to analyze what's going on here, but I think everybody can see that there's a neighborhood of bradycardia and tachycardia that is going on. And there are at least 3 to 4 mechanisms for bradycardia and tachycardia, what you can see already on this page. So this is really challenging for us all and challenging for you as pediatric cardiologists, for surgeons, and for us as acting as electrophysiologists, or better to say electrocardiologists. And when we think about transposition of the great arteries, what comes up into our mind according to arrhythmias, we see the whole wide span of arrhythmias we can have. We have all bradycardia types, we have any type of supraventricular tachycardia, so to say, congenitally giving AV nodal reentry tachycardia, or Wolff-Parkinson-White syndrome. We have everything that can go on a tachycardia basis, on atrial level or on ventricular level. And the neighborhood or the mixture of these arrhythmias in one patient, they are causing a rhythmological dilemma, which is hard to summarize in 20 minutes that are given for this talk. So looking from electrophysiologist's view, we sort the anatomy for sure, as you do and as it has been done all over the whole meeting and the whole session, according the classical detransposition, congenitally corrected transposition of the great arteries, and plus or minus surgery according to this group, and the more complex group that I have today to rule out, because we cannot draw any systematical conclusions for these patients. They are more anecdotal data, and they are the more rare patients. But according to the arrhythmia substrate, we have to sort these arrhythmias that are coming up according their origin, whether they are congenitally given or associated to the congenital heart defect. For example, the Wolff-Parkinson-White syndrome, as we know it, for some patients with CCTGA, when they have additional Epstein malformation, we know that they have a higher association to this defect. And then the question is, if these patients have these arrhythmia forms or this congenitally given substrate, and how we can access this substrate. The next group is acquired via surgery. This is the big group of arrhythmias we are dealing with. On the atrial and on the ventricular level, and here we are forced to find out critical regions, and we have a growing group. The older this group of patients is becoming, they are acquired via aging, myocardial aging, fibrosis, and all the effects of heart failure. And I concentrate for this presentation on the 2 groups I mentioned before: transposition of the great arteries, detransposition and congenital malformation, and the congenitally given and acquired surgery. Looking into the literature, we find only a few data about the occurrence of these arrhythmias. And in all the presentation I listened today and yesterday, we are again seeing that there are not too many data about the occurrence of arrhythmias in these groups. From the Boston group, we have a relative risk for arrhythmias that has been shown. Here on the left side, you see some groups of congenital heart defects, and on top you see different types of tachycardia or bradycardia types. And if we concentrate again on DTGA or CCTGA, here the lower group, and if you sum these asterisks that give the relative risk of the occurrence of arrhythmias, you can see that these 2 congenital malformations are giving rise for all the arrhythmias we can have in our patient cohort. From Carol Warren's group, here Mayo Clinic, we have some data about the long-term follow-up in mustard patients. I would say that this is more or less the same for sending patients. that we have to count with a 30% likelihood or more for atrial tachycardias. Typically atrial reentry tachycardias, the less of these are focal of origin and the long-term follow-up, next to the bradycardia problems and next to some ventricular arrhythmias or sudden cardiac. That's what my second speaker, Joachim Hebe, will cover. And this is a publication from a Japanese group, multi-center analysis of long-term follow-up of atrial switch patient cohort, the more modern operation type. That was a cohort study of 6 institutes in Japan, and they summarized a little bit more than 600 patients, and you can see about 10% of these patients, they developed significant arrhythmias. The arrhythmia-related number of deaths, so-called sudden cardiac deaths, according to arrhythmia or infarction, more likely to be according to arrhythmia, were only encountered in 2 of the 624 patients. And if you look then what these significant arrhythmias have been, we see that 1/3 of it was bradycardia, and we heard this already today, and then 1/3 were supraventricular tachycardia or ventricular arrhythmia, the lower group. But again, a little lower number as we have seen in the atrial switch operation group. And to come a little bit further, we looked in our Bremen data, and I did this together with my co-worker, Dr. Jan Nürnberg, but I like to thank here very much for his work, that, and he was already encouraging me to counter our numbers, what we have done in the 10 years in Bremen, according with patients with transposition or malposition of the great arteries. And again, we assorted them to detransposition, CCTGA, and the more complex situations with univentricular hemodynamic hearts. And I would like to start with the DTGA group. And we have seen in these 59 patients with DTGA, we have done electrophysiologic study or intervention and could find out mechanisms and substrates of 65 tachycardias. Here are listed the types of surgery that have been done. 20 patients were after mustard procedure, 25 after sending procedure, 5 only after Rastelli, kind of Rastelli procedure, and 9 patients after arterial switch. And down here you see the tachycardia types that have been seen in these patients. Here, the bradycardia, again, this will address Joachim Hebe, this group of patients, only 1 with ICD, already presented from another center, and the high number of bradycardia problems resulted in pacemaker implantation in 15 patients. So I just would like to show this Cook diagram. Maybe this is related to the fact that both Jan Nürnberg and we like to eat Cook a lot, and it's the first time that I show a Cook diagram. I only show numbers typically, but it nicely shows that there's a dominant tachycardia form, which is the atrial reentry tachycardia. And what we did not know so far, but we found out with this analysis, that another big group of arrhythmias that occurred in this patient cohort was AV nodal reentry tachycardia. So the typical form of AV nodal reentry tachycardia, which so far we did not know has a high likelihood to occur in these patients, at least according to our patient data. If you go to the patients after Rastelli procedure, we found 6 tachycardia types or substrates, and you can see more problems on the ventricular level, but again, dominant problem on the atrial level, atrial reentry tachycardia, presumably coming from the results or the effects from atrial cannulation going to the heart-lung machine. Arterial switch procedure, and there were only 7 tachycardias defined in these 9 patients. 2 of them had failure of definition of the tachycardia mechanism, and you can see here a whole mixture of tachycardias. 1 congenital form with Wolff-Parkinson-White syndrome, and the rest more on the ventricular level, but even on the atrial level. So no tendency towards one type of tachycardia, in contrast to the mustard and sending group, where we have a dominating group of atrial reentry tachycardias. And I would like to focus on these. We have done electrophysiologic intervention attempt. This is EPI intervention attempt in 74 of the 59 patients according to these tachycardias. I would like to go a little bit more into detail with atrial reentry tachycardia, which is the biggest cohort, as said before. And you many of you might have seen these pictures before, but I just thought I show it again because it is very nicely seen in these reconstructions, three-dimensional reconstruction, how these tachycardias typically take their way in patients after mustard or sending ablation. You see here lateral view on the atrial cetus. This is the pulmonary venous atrium. This is the systemic venous atrium. You see here the tricuspid valve open, and you see here the mitral valve open. And the tachycardia, you will see it in a second, is taking its way around the tricuspid valve annulus typically within the pulmonary venous atrium. This is an animation of the activation front, and you can see nicely that this tachycardia is circling around the tricuspid valve annulus. The ablation concept for sure consists of blocking these paths, these myocardial paths, through this covered tricuspid isthmus, so to not allow the tachycardia mechanism to take its way again through this critical region. And today we are even able to validate such an electrical dissection. What we are aiming at, this is another patient. Again, here on the left panel you see the pulmonary venous atrium, systemic venous atrium, insertion of the inferior carpal vein, which is, according to the surgery, directed towards the systemic venous atrium. On the left panel, you see before ablation, on the right panel after the ablation, and the validation concept, we are rotating now the heart towards the back, so we're looking from below, from the feet, so to say, that we are pacing on one side of this critical path. The critical path, the covered tricuspid isthmus, is located here. We are looking here to the bottom of the tricuspid valve annulus. Again, here's the vein, insertion of the inferior carpal vein, and the pacing side, as you can see from the red color, where the earliest activation in the heart is during atrial pacing, is giving an electrical activation through this path, through the covered tricuspid isthmus towards the free wall of the pulmonary venous atrium. And this is a situation after we have blocked this area, and you can see that the latest activation, color-coded in pink, is always the last try, so you can keep that in mind, in pink, or in purple. It's better to say in purple, it's the last try, as we say in Germany. You can see earliest activation here. Here's a blocked line. Activation has to go all the way long around the tricuspid valve annulus on the rooftop to come latest on the opposite side of the electrical dissection. So this is a situation where we turn to be happy in the electrophysiologic setting, and where we can have a 80 to 85% likelihood of having blocked for a long time these covered tricuspid isthmus. And if you look into the literature, these are the rare publications over the last 10 years that we have according mastered patients or sending patients. Typically reports about mastered patients, I would presume, because they are more existent in the international setting. We can see that the covered tricuspid isthmus is the most relevant area for the tachycardias that needs to be blocked. The problem is how we can access this area, and this is maybe something what we have to think about in a surgical setting, as here too. From a Cantor publication, you can see the variation in sending procedures or master procedures and sending procedures according whether the baffle is sutured on the either or the other side of the drainage of the coronary sinus, which is marked here. So there are some variations, but typically it excludes from the venous access the majority part of the covered tricuspid isthmus, which is located here. Here's the tricuspid valve annulus. Here is the insertion of the pulmonary veins. On the other side of the atrium, you can see here the position of the AV node again, which for the surgeon is again an area that he has to exclude so that the suture line is not going through the AV node, otherwise we are risking a complete AV block. So this area now here we are looking at is always on the pulmonary venous atrium. Maybe you can see it even here, Eustachian ridge, coronary sinus, tricuspid valve annulus. This is the atrioseptectomy. This is the insertion of the mustard baffle, and this mustard baffle will be inserted along this line. So this is the problem where we are facing, what we are facing whenever we are having a patient after mustard or sending operation, because the tachycardia is using this part of the myocardium, the so-called covered tricuspid isthmus. And if I would go into the feeling of a reentry circuit, if I would be tomorrow a reentry circuit, I would use these parts because this is perfectly made for running around. This is like an autobahn. This is something what we should keep in mind whenever these procedures are still done, and I come later on to this, sometimes then this is just a dye injection into the pulmonary venous atrium. You can see here the borders, and after having done a transbuffal puncture, we are able to insert, in some of these cases, the catheter towards the pulmonary venous atrium and not going through the retrograde approach with the transaortic approach entering the pulmonary venous atrium. This is from our data until 2009, and you can see again in mustard patients we had most problems if we were dealing with AV nodal reentry tachycardias, I come later on, or atrial reentry tachycardias. We had to go to the pulmonary venous atrium in the majority of patients, and if we look how many of these patients, of these 11 patients, had a leakage in the buffle, in the mustard buffles, there were only 5, and 3 of them were accessible with the catheter, so the pulmonary venous atrium was accessible, and 2 of them we had we had to do an additional puncture of the leakage because it was not appropriate for entering the pulmonary venous atrium. In 3 patients we had to go retrograde, which is really crossing 2 valves, the aortic valve and the tricuspid valve, is limiting our access to the pulmonary venous atrium. Just ending up with this patient cohort, AV nodal reentry tachycardias, as mentioned before, we had in 10 patients, which is quite a high number. And just to show you, we have on the atrial level for sure no anomaly in these patients to be expected, because the atrial cetus and transposition of the great arteries is normal. In the detransposition patients, there's only surgical access. The access by surgery is a little bit more difficult. So in this situation, we go via the retrograde route, transaortic into the right ventricle, and then across the tricuspid valve towards the area where we expect the slow pathway region to be, where the AV nodal reentry tachycardia takes its critical path in order to block this. Just to summarize quickly the results, out of 47 patients, we were able to do a successful intervention in 41 of these patients within 56 sessions. So I think it expresses nicely the complexity to get abolished 55 of 63 found substrates in the electrophysiologic study. The last minutes I would like to spend with congenitally corrected transposition of the great arteries. These 20 patients, what did we find here in these patients? Again, here are listed the arrhythmias we have found in these patients. 3 of these patients had additionally a Epstein's anomaly, which is quite frequent to be seen in these patients. As we know, 4 patients had VSD, 1 PA atresia, and 1 hypoplastic aortic arch. Next to the bradycardias, what we are expecting, especially on the AV node level, we found these tachycardias, and again, this Cook diagram shows that we have a whole variety of arrhythmias, and I would like to concentrate on the congenital form, the Wolff-Parkinson-White syndrome, and show one example here, which was done in the previous, I went to Bremen. This is one example I have done one patient I have done in Hamburg time, 1997, but it's a very nice example of a young boy who had a CCTGA plus an Epstein malformation. And what you need to know is that when we go to the left side of the heart to map accessory pathways, to find left-sided accessory pathways, and we are dealing maybe with multiple accessory pathways, we need the coronary sinus to access from the transvenous route, to have a stable catheter position within this coronary sinus. So we always aim to find a way here. And after 2 sessions, we find out via a coronary angiogram that the coronary sinus in this patient, we are looking in an LAO view now to the heart, that this coronary sinus took a very anomalous way. This is around the left-sided tricuspid valve annulus. Here's the interatrial septum where we were used that the coronary sinus is now connected towards the right atrium, but it takes another longer distance and ends up here right anterolateral into the right atrium. And having found this, we were able to block in these patients 3 accessory pathways. As we typically know from Epstein patients, even patients that have CCTGA plus Epstein, we have multiple accessory pathways to be found. And here we found 3 of them all on the left side, and were able to block them. And the need to block them is maybe shown here in this example. atrial fibrillation in this patient cohort is more likely than in patients with normal hearts, especially when they are having Epstein malformation plus multiple accessory pathways. And this is by chance a lucky outcome of this situation, but this could end up in ventricular fibrillation and end up the life of the patient. In 14 of these 16 patients, we were able to successfully treat them in 25 sessions. Again, an expression of the complexity of the situation. There were many failures and there were many recurrences in these patients. And I think of note was that of 3 patients with Wolff-Parkinson-White syndrome, 1, 2, and 3 accessory pathways each have been found, and 2 out of these patients, and 1 presumably had an Epstein anomaly, and 1 patient it was not very clear by echo parameters. And the other important point, I think, is of 3 patients with atrial-oriented tachycardias, 2 had undergone a double switch procedure. Double switch procedure on the atrial level of descending type, which creates the same problem today what we have created 30 years ago when mastered or sending procedures were the typical way to operate these patients. So we cannot look at these patients and say, okay, this is a problem of yesterday, at least in the Western world. In the Eastern world, we know it is done still as a typical procedure. But it is a problem of today, as at least if we think of a double switch procedure, because we create the same problem. So we should rethink whether maybe this ablation line should be implemented in the surgical methodology. So the take-home messages of this talk should be antiarrhythmic treatment, meaning medical antiarrhythmic treatment, is difficult because we are very often seeing a neighborhood or a simultaneous existence of bradycardia problems and tachycardia problems. If you think of mustard sending patients with sinus node dysfunction or CCTGA patients with respect to AV block, and whenever you try to treat them with conventional medication, this is one example. This is very heroic, I would say. This is a supraventricular tachycardia with IV beta blocker on such a patient, blocking it. This is after some seconds. And at least here we get nervous, I would say, if you have no backup. So this is something we have to avoid. And we have potential life-threatening situations, especially in these patient cohorts, while supraventricular tachycardia. So these so-called benign supraventricular tachycardia, they are in these patient cohort for sure not benign. They are potentially life-threatening. We know, and this was addressed extremely in this meeting, we have very often in these patients in the right ventricle in place of the systemic ventricle with a reduced coronary reserve, reduced systolic function, with an impaired diastolic function, less tolerable to these supraventricular tachycardias. So this is a domain of catheter ablation, and we see, and we have learned within the last 20 years to have their good results. In mustard sending patients, most atrial tachycardias take their way through the carbotricuspid isthmus, which is good for us to know, hard for us to achieve because it is on the pulmonary venous atrium. For mustard patients and sending patients, many patients with AV nodal reentry tachycardia, we don't know why, but we have seen it now in 10 out of 49 patients. We have double switch patients with exactly the same situation on the atrial level like mustard sending patients, as mentioned before. And in patients with CCTGA, we always have to take into account that there could be an Epstein anomaly, and with the Epstein anomaly, we have a high risk of the existence of accessory pathways, and for this, a high risk for severe tachycardia. And we have an unpredictable cause of the coronary sinus, as we found in many other patients. Atrial fibrillation, last slide, will become a problem with aging of this patient population, especially of the CCTGA population. When we meet in 2023, Felix, I hope that we will have this meeting then again. We will talk maybe 80 to 90% about atrial fibrillation in these patient cohort. And arterial switch, we will see what is the outcome with respect to arrhythmias. So far, I would have the prognosis that they have a better outcome. They have less arrhythmia problems in these patient cohort, but this is a younger patient cohort. If we look into our patient cohort, they have been at admission in an average 9 years compared to the patients with mustard sending or Rastelli procedures that had a mean age of 26 years. So we are at the very beginning of looking at these patients. Thank you.